Morning. My name is Dr. Mazin, a pediatric registrar in Our Lady of Lourdes Hospital, Drogheda. So, in this presentation, we will do the neonatal resuscitation program. So, the main source to study for the NRP, this is the 8th edition. So, copyrights to the American Academy of Pediatrics, and the American Heart Association. So this is the 8th edition of the NRP Neonatal Resuscitation Program. All right. So this is the textbook of the neonatal resuscitation, the 8th edition. So neonatal resuscitation program course overview. So the neonatal resuscitation program materials are based on American Academy of Pediatrics guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. So the level of responsibility. So the 8th edition offers two NRP provider categories. So the first category, the NRP essential. So anyone involved in the care of a newborn should take NRP essentials, which consist of material in lesson 1 through 4. And the NRP advanced, this provider option may be appropriate for those who attend births and are responsible for anticipated resuscitation of the newborn with known risk factors. For those who participate in neonatal resuscitation beyond positive pressure ventilation. So I think this is mainly for the registrars, pediatric registrars, and the residents. So this type of people should go through from lesson 1 to lesson 11. Okay, so I'll show you the lessons. So lesson 1 is called Foundation of Neonatal Resuscitation. Lesson 2, Anticipation and Preparing for Resuscitation. Lesson 3, Initial Steps. Lesson 4, Positive Pressure Ventilation. So this is the cutoff for the NRP essential. And all this for the NRP advanced, until lesson 11, is it? Yeah. So NRP advanced. So lesson 5, intratracheal intubation, chest compressions, medications, resuscitation and stabilization of babies born preterm, post-resuscitation care, special consideration, ethics and care at the end of life. And lesson 12, improving resuscitation team performance. Lesson 13, resuscitation outside the delivery room. And lesson 14, bringing quality improvement to your resuscitation team. All right. So we start with lesson 1, foundation of neonatal resuscitation. So the key points here. Most newborns make the transition from the extrauterine life without intervention. Okay. So before birth, pulmonary vessels in the fetal lungs are tightly constricted and the alveoli are filled with fluid, not air. Newborn resuscitation is usually needed because of respiratory failure. The most important and effective step in neonatal resuscitation is to ventilate the baby's lung. So ventilation is the most important thing. Teamwork, leadership, and communication are critical to successful resuscitation of the newborn. All right. So the neonatal resuscitation program will help you to learn the cognitive, technical, and teamwork skills. So actually, these are some facts you need to know. Actually, 5% of term newborns will receive positive pressure ventilation. So a small percentage. 2% of term newborns will be intubated, and one to three babies per 1,000 births will receive chest compression or emergency medication. Okay, so the likelihood, what determines which child needs resuscitation or needs positive pressure ventilation or intubation or these things is the risk factors, So you have to know if there is any identified risk factors for those born before full term. Okay, and during the NRP you learn how to evaluate a newborn, to make a decision, actions, and all this stuff, So how is the neonatal resuscitation program algorithm structured? So the first thing you need to know is something called NRP algorithm. So I'll show you the NRP algorithm. So it describes the steps that you will follow to evaluate and resuscitate a newborn. So it is divided into 5 blocks, beginning with birth and the initial assessment. So it is 5 blocks. All right. So throughout the algorithm, hexagons indicate assessment and rectangles show the actions that may be required. Although it is important to work quickly and efficiently, you must ensure that you have adequately performed the steps of each block before moving to the next block. Assessments are repeated at the end of each block and will determine if you need to proceed. The details of each block are described in subsequent lessons. All right. So this is the NRP algorithm. So you have 5 blocks. So A, B, C, D. All right. So we'll go through all these things as we go through the presentation. All right. So the rapid evaluation determines if the newborn can remain with the mother or should be moved to a radiant warm for further evaluation. So it is A, B, C, D. So A for airway, and B for breathing, and C for circulation, and D for drug. So perform the initial steps to establish an open airway and support spontaneous respiration. Breathing, positive pressure is provided to assist. Breathing for babies with apnea and bradycardia. Other interventions like CPAP or supplemental oxygen may be appropriate if the baby has labored breathing or low oxygen saturation. So the oxygen saturation, there is, so this is the target for the oxygen saturation, depending on what time the baby was delivered. So 1 minute is 60 to 65, 2 minutes 65 to 70, 3 minutes 70 to 75, 4 minutes 75 to 80, and 5 minutes is 80 to 85. So that's why it is important to just start a timer when you're doing the Apgar score. Okay, there is a timer in the machine. So just you need to know at what time what is oxygen saturation, so then you can know what is going on. All right. And the initial oxygen concentration for PBV for babies who are 35 weeks gestational age and more, it's 21% oxygen. and less than 35 weak station, so it is 21 to 30% oxygen. All right. So the neonatal resuscitation program key behavioral skills. So the first thing, know your environment, use available information, anticipate and plan, clearly identify a team leader, and communicate effectively, and delegate workload optimally, and allocate attention wisely. Use available resources, call for additional help when needed, and maintain professional behavior. All right, so I'll go through all these things. So what do we mean by know your environment? So know the location of the resuscitation equipment and how to access it. This is very important. Know how to call for help and who is available. So know the use the available information. Know the prenatal intrapartum history, including in maternal communications and maternal medications and the risk factors. So anticipate and plan. So perform a pre-resuscitation team briefing to ensure all team members know the clinical situation, assign the roles and responsibilities, and then discuss an action plan in the event of complications. So, and clearly identify team leader. So identify the team leader before pairs. This is very important. Effective leaders clearly articulate goals, delegate tasks as appropriate while monitoring the distribution of workload, include other team members in assignment and planning, think out loud, maintain situation awareness, hand over leadership to another team member if they must become involved in a procedure. So communicate effectively, call team members by name. This is very important. So you need to know the names of your team members. Share information actively. Inform your team if you identify a problem, error, or patient safety. Order medications by name, dose, and route. So you need to have a clear orders. Okay, so you have to say if it is epinephrine, for example, you have to say the dose, is it IV or so. You need to say the order clearly, So use concise, clear language. Use closed loop communication. So this is very important. You need to know what is closed loop communication. So verify information. Ensure that the changes in information or assessment are shared with all team members. Include the family members in communication as appropriate. So do not delegate work optimally. Do not duplicate work or use more resources than necessary. Change task assignment depending on the skill set and what is required at the moment. Do not allow one person to become overloaded with tasks. This is very important. Do not allow team to become fixated to a single task. All right. So allocate attention wisely. Maintain situation awareness by scanning and reassessing the clinical situation frequently. Monitor each other's skill performance to ensure patient safety. Use available resources. Know what personnel are available. Know what additional or special supplies are available and how to access them. So call for help if needed. So anticipate the need for additional team members based on the risk factors and the progress of the resuscitation. Call for additional help in a timely manner. Know how you will call for additional help and the process for getting the right kind of assistance. So maintain a professional behavior. Use respectful verbal and non-verbal communication. Actively seek and offer assistance. Support and promote teamwork, respect, and value your team. All right. So this is lesson 1. So we'll go to lesson 2, which is anticipating and preparing for resuscitation. So you will learn in this section, you will learn the risk factors that help you to predict which baby will require resuscitation. So 4 key questions. So you need to know the 4 key questions to ask to the obstetric provider, the midwife. So how to determine who should attend a birth, how to perform a pre-resuscitation team briefing, how to assemble and check resuscitation supplies and equipment. So and why accurate documentation is important. So accurate documentation is very important. So in this section, the most important are seeing as the risk factors, the 4 key questions, and documentation. Okay. So what are the 4 questions you need to ask before pairs? What is the expected gestational age? Is the amniotic fluid is clear? Is the amniotic fluid clear? Are there any additional risk factors? What is our umbilical cord management plan? So some newborns without any apparent risk factors will require resuscitation sometimes. Every pairs should be attended by at least one qualified individual who can initiate resuscitation and whose only responsibility is the management of the newly born baby. All right. So every pairs should be attended by at least one qualified individual. If risk factors are present, at least 2 qualified individuals should be present solely to manage the baby. And the number of and qualification of this individual will be determined by the risk factors. Okay. So a child maybe who may need an intubation, so the person available should have a good experience with intubation, for example. So and a qualified team and full resuscitation skills should be identified and immediately available for every resuscitation. The fully qualified resuscitation team should be present at the time of birth. If the need for advanced resuscitation measures is anticipated, all supplies and equipment necessary for a complete resuscitation must be readily available and functional for every birth. So the equipments are very important also. So we'll have this is a case actually. 30-year-old female come to the hospital in labor, 36-week gestation, insulin requiring gestational diabetes, hypertension. So these are the risk factors. She's found to have ruptured membranes with clear amniotic fluid. Fetal heart rate monitoring shows category 2. And and possibly other tests to ensure fetal well-being. Labor progressed rapidly and vaginal birth is imminent. So the obstetric providers call you your resuscitation team to attend the birth. So you ask the 4 questions. So what are the 4 questions now? You know it. So what are the 4 questions now? What is the gestational age? Is the amniotic fluid is clear? Are there any additional risk factors? What is your umbilical cord? What is our umbilical cord management plan? So then you identify a team leader and everyone knows his responsibility and complete equipment check. All right. So introduce yourself to the mother and the obstetric team and take your position near the preheated radiant warmer. All right. So why is it important to anticipate the need for resuscitation before every birth? So at every birth, you should be prepared to resuscitate the newborn. This table describes the risk factors that increase the likelihood that a newborn will require support with transition or resuscitation. Throughout thoughtful consideration of these risk factors will help you to identify the correct personnel to attend the birth. So we'll go through these risk factors. So there is antepartum risk factors and intrapartum risk factors. Okay. So what are the antepartum? Antepartum means before the delivery, and intrapartum means maybe during the delivery. Okay. So gestational age less than 36 weeks, and gestational age greater than or equal 41 weeks, preeclampsia, eclampsia, maternal hypertension, multiple gestation, twins or 3 babies or 4 babies sometimes, fetal anemia, polyhydramnios, oligohydramnios, fetal hydrops or hydrops fetalis, fetal macrosomia, intrauterine growth restriction, IUGR. So significant fetal malformation or anomalies, for example, like diaphragmatic hernia, tracheoesophageal fistula, any fetal anomalies, anencephaly. So any fetal anomalies. Okay. So or a mother who with no prenatal care. Okay. So the intrapartum risk factors: emergency cesarean delivery, forceps or vacuum assisted delivery, breech or other abnormal presentation, category 2 or 3, fetal heart rate pattern, maternal general anesthesia, maternal magnesium therapy, placental abruption, intrapartum bleeding, chorioamnitis, opioid administered to the mother within 4 hours of delivery, shoulder dystocia, meconium stent, amniotic fluid, and prolapse umbilical cord. So what are the questions you should ask before birth? So I will repeat them again. What is the expected gestational age? Is the amniotic fluid is clear? Are there any additional risk factors? What is our umbilical cord management plan? All right. So every birth should be attended by at least one qualified individual, and if risk factors are present, then 2 qualified person at least. So that's it. All right. So how do you perform pre-resuscitation team briefing? So so it depends on the situation, you can just read the slides. Yeah, no need to go through it. Neonatal resuscitation team briefing. So the pre-resuscitation team briefing assess the risk factors, identify the team leader, anticipate potential complications, and plan a team response, delegate tasks, identify who will document, determine what supplies and equipment will be needed, identify how to call for additional help. All right. So if you are working, for example, in a hospital, you need to know what phone number you should call to get, for example, the consultant, or if it is an emergency, you need to call everyone. So you need to know these things. This depend on each hospital, So what supplies and equipment should be available? So there is a list, there is checklist. Okay, we'll go through all these things. So the characteristics of an effective team leader. So good communication skills, giving clear directions to specific individuals, sharing information. Okay, to ensure coordinated care, maintain professional environment. Skilled leader effectively use resources by allowing all team members to contribute their unique talents to the resuscitation process. It is important for the team leader to remain aware of the entire clinical situation, maintain a view of a big picture, and do not become distracted by single activity. This is called situation awareness. Situation awareness. So if the leader is involved in a procedure that diverts their attention, the leader may need to appoint another qualified person to assume the leadership role. If the person in the leadership role changes during the resuscitation, a clear verbal statement should be made so that all team members know who is the leading team. All right. So the NRP quick equipment checklist. So this is all the checklist. So warm, clear airway, auscultate, ventilate, oxygenate, intubate, medicate. So a preheated warmer, warm towels or blanket, temperature sensor and sensor cover for prolonged resuscitation, hat, plastic bag, or a plastic wrap for less than 32 weeks gestation, thermal matters for less than 32, bulb syringe to clear the airway, 10F or 12F suction catheter attached to the wall suction, set at 80 to 100, and tracheal aspirator and stethoscope, ventilate, so flow meter set to 10 liter per minute, oxygen blender set at 21 and 21 to 30 if less than 35 gestational age. So positive pressure ventilation device, term and preterm sized mask, 8F orogastric tube and 20 ml syringe, laryngeal mask size 1 and 5 ml syringe if needed for inflation, 5F or 6F orogastric tube if insertion port is present, or laryngeal mask, cardiac monitors and leads, equipment to give free flow oxygen, pulse oximeter with a sensor and cover, target oxygen saturation table, laryngoscope for intubation, size 0, 1, straight plate, and size 0, 0 is optional. So you need to know which size for which age actually. So it is 0 and 0, 0 and 1. All right. So stylet optional, endotracheal tube size 2.5, 3, 3.5. You need to know the gestational age for each tube and the depths of the tube, CO2 detector, and you need to know the color change, which is the purple or the orange. So measuring tape, endotracheal tube insertion, waterproof tape, and scissors. All right. So medicate, access to epinephrine 0.1 milligram per ml, which is 1 milligram per 10 ml, normal saline 100 ml or 20 250 ml bag or pre-filled syringe. Supplies for placing emergency umbilical venous catheter, UVC, and administering medications. So a table of pre-calculated emergency medication dosage for babies with a weight between 0.5 to 4 kilogram. All right. So I mentioned something called closed loop communication. So I need to clarify what is closed loop communication. So although a team has a leader, each team member shares responsibility for ongoing assessment, ensuring the interventions are performed in correct sequence with the correct technique. So successful coordination requires team members to share information and communicate with each other. So closed loop communication is a technique used to ensure that instructions are heard and understood. So when you give an instruction, so direct the request to a specific individual. So for example, James, can you just check for example the saturation or anything? So call your team member by name. So you need to know the names first. So and you have to make an eye contact. This is very important for communication. And speak clearly, speak loud. So after giving an instruction, ask the receiver to report back as soon as the task is completed. After receiving, we'll give an example, and there is 2 examples actually here. After receiving an instruction, repeat the instruction back to the sender. So the following are 2 examples to demonstrate closed loop communication. All right. Example, Nicole and Lou. So Lou, I need a 3.5 millimeter endotracheal tube with a stylet laryngoscope with a size 1 plate now. Tell me when they are ready. So Lou should respond and say, you need the 3.5 millimeter endotracheal tube with a stylet and a laryngoscope with a size 1 plate. Nicole, correct. So correct once equipment is ready. Nicole, a 3.5 millimeter endotracheal tube with a stylet and a size 1 laryngoscope are ready for you now. So this is an example for closed loop communication. Okay, you can read this example also. I just leave the slide for a while. And so we mentioned all the equipments. So documentation. Why documentation is very important during an emergency? Highly effective team accurately document the series of events as they occur. Complete and accurate documentation is important for clinical decision making and as a source for quality improvement data. All right. The sense of urgency surrounding resuscitation can make accurate documentation challenging. So preparation can make this essential tasks easier. So what are the initial steps of newborn care? This is lesson 3. So we learn how to perform a rapid evaluation, the initial steps of newborn care, how to determine if additional steps are required, what to do if a baby has persistent cyanosis or labored breathing, and how to use a pulse oximeter and interpret the result, and how to give supplemental oxygen and when to consider using continuous positive airway pressure, and what to do when meconium stained amniotic fluid is present. All right. So this is the algorithm. So the key point: for most vigorous term babies and preterm newborn, clamping of the umbilical cord should be delayed for at least 30 to 60 seconds. So for most vigorous term and preterm, so it is 30 to 60 seconds. All right. All newborns require a rapid evaluation. Ask the baby if the baby's term has a good tone, muscle, and is breathing or crying. If the answer is no of any of these, the newborn should be brought to the radiant warmer for initial steps of newborn. All right. So you need to ask, is the baby term? What about the tone? He have a good muscle tone? Is he breathing or crying? If the answer is no for any of these questions, the newborn should be brought to the radiant warmer. So the 5 initial steps include the following: provide warmth, dry, stimulate, position the head and the neck and to open the airway and clear the secretions from the airway if needed. So dry, stimulate, position the head to open the airway, clear secretions if needed. I forget warm first. Warm, dry, stimulate, open airway, clear secretions if needed. So use a pulse oximeter and the target oxygen saturations according to the table. So as I showed you before, and so these are the indications to use a pulse oximetry. Okay, when resuscitation is anticipated, to confirm your perception of persistent central cyanosis, if you give supplemental oxygen and if pressure ventilation is required. So visual assessment of cyanosis is not a reliable indication of oxygen saturation. It's not a reliable indicator. So if meconium stent fluid is present and the baby is not vigorous, bring the baby to the radiant warmer to perform initial steps. Routine laryngoscopy with or without intubation or tracheal suction is not suggested. All right. So when should the umbilical cord be clamped? So at time of birth, a large volume of the baby blood remains in the placenta. If maternal blood is still flowing to the placenta and the umbilical cord has not been clamped, placental gas exchange will continue and additional oxygenated blood will be returned to the baby through the umbilical vein. This blood may play an important role in the newborn baby transition from fetal to neonatal circulation. So mark the time of birth, starting a timer when the last fetal part emerges from the mother's body, and the ideal time for clamping the umbilical cord is subject of ongoing research actually. So what I want to say is, in preterm newborns, potential benefits of delayed cord clamping compared with immediate cord clamping include decreasing the chance of needing medications to support blood pressure after birth, requiring fewer blood transfusion during hospitalization, and possibly improve survival. In term babies and late preterm, delayed cord clamping may provide early hematologic measurements, and although uncertain, there may be a benefit for neurodevelopmental outcomes. However, there may also be increased chance of needing phototherapy for hyperbilirubinemia. All right. So before birth, establish with the obstetric provider the plan for timing for umbilical cord clamping. So for most vigorous preterm newborns, the current evidence suggests that clamping should be delayed for at least 30 to 60 seconds. Among vigorous term newborn, the evidence suggests that a similar delay may be reasonable. During this time, the baby may may be placed skin to skin on the mother's chest or abdomen, or held securely in a warm, dry towel or blanket. Very preterm newborns, less than 32 weeks, may be wrapped in a warm blanket or a polyethylene plastic to help maintain their temperature. Remember, until cord is clamped, the baby will also be receiving warm blood from the placenta. During interval between birth and umbilical cord clamping, the obstetric provider and neonatal team should evaluate the baby's tone, breathing efforts, and to continue initial steps of newborn care described in the remainder of this lesson. So I will stop in this slide. And next time I will complete from this slide. Okay.